Hello and welcome to our live stream. I'm Ed Bottomley with the Michigan Medicine Department of Communication. February is Heart Month. Heart disease has long been the leading cause of death in the US for women, causing 1 in every 5 female deaths. Today, we're going to be talking about heart disease and how it manifests in patients who are assigned female at birth. Today's panelists join us from the University of Michigan Health Frankel Cardiovascular Center. And if I could have all three of our panelists just introduce themselves quickly. Let's start with Dr. Duvernoy.
Hi, everybody. I'm Claire Duvernoy. I've been with Michigan Medicine for longer than I would care to say, my entire career. I started the Women's Heart Program here about 20 years ago. I've been an interventional cardiologist on the Michigan Medicine faculty for over 20 years, and I'm now doing consultative cardiology. I also spend a significant portion of my time at the Ann Arbor VA Medical Center taking care of veterans with heart disease. So I'm really pleased to be here. I'm a Michigander native, grew up here, was born in Detroit, and I'm happy to be here.
Thank you so much. And Dr. Saberi?
Hi, I'm Sara Saberi. I've also spent my entire medical career here at the University of Michigan. I specialize in inherited cardiomyopathies, so genetic heart muscle disorders that run in families, and have another specialty in cardiac imaging, and also happy to be here.
Fantastic. Happy to have you on board as well, Dr. Saberi. And finally, Dr. Bisognano.
Hi, I'm John Bisognano. I did my training here at the University, some of my training here at the University of Michigan, and I'm the Director of General and Preventive Cardiology, specializing in severe and resistant high blood pressure, as well as cholesterol treatments. Pleasure to be here.
Yes, absolutely. And before we start, just a few housekeeping items. You can submit questions at any time for our panel to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or profile name will be visible to others participating. If you prefer a more anonymous option, you can also send a private message to us via the social media channel you're watching on. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine YouTube channel later. So I think we should get down to the questions. Let's kick off with our first question, and I'll send it to Dr. Duvernoy first off. What are the biggest differences between people assigned male at birth and people assigned female at birth when it comes to heart health and cardiovascular risk? And what's the same for everyone?
Well, so let me start out with things that are really the same. Sadly, cardiovascular disease is the major killer for both men and for women in this country. And I think that sometimes we lose sight of that fact because women tend to present with heart disease symptoms and cardiac events about 10 years later than men do. And they also may present with symptoms that are somewhat different, maybe not as easy to put into that box, oh, this is definitely heart disease, because they may not have sort of the classic crushing chest pain radiating up to the neck or the jaw. They may present more with symptoms like extreme fatigue or shortness of breath, or I can't keep up with the things that I used to be doing. And sadly, oftentimes they put that down to, well, I'm just out of shape, or it's, women especially tend not to think that this might be their heart giving them a problem. Risk factors between men and women are, some are very similar or the same. High blood pressure is a risk factor for men and for women. Smoking is, if anything, even a bigger risk factor for heart disease in women than it is for men. Same goes for diabetes, major risk factor for both men and women. If anything, even larger for women than it is for men. And then there's some things that seem to be unique or especially prevalent in women. We're learning a lot about post-traumatic stress disorder and depression and anxiety and how those factors can play into heart disease risk. That's true for men and for women, but we tend to see that especially in women. And then there are disease presentations, and we can get into that more a little bit later, but things like microvascular disease and disease that is more diffuse along the coronary arteries rather than causing discrete focal lesions in the coronaries may be more common in women than it is in men. So those are some things to start out with that are similarities as well as differences.
Thank you so much. Do either of our two panelists want to add anything to this?
I think Claire handled it.
Perfect. Perfect. The next question that we have up, what are the symptoms of a heart attack in patients assigned female at birth? How do symptoms of a heart attack vary by age and or by sex?
So I can start it with that one also. As I said initially, there are some things that are the same between men and women and some that are different. And chest pain is certainly a symptom that could be indicative of a heart condition in both men and in women. So I don't want to say that chest pain is not a symptom of heart disease in women, because it definitely is. But women may also have more diffuse types of symptoms or more symptoms that they may not immediately pinpoint as being heart related, like shortness of breath, extreme fatigue, pain across the whole upper body or across the back. Those types of things that are just a little bit harder to quantify. And then when you're looking at ages, especially in younger age groups, women oftentimes will miss or not recognize that what they are having is a cardiac issue. And we see that younger women especially have delays in recognition and delays in treatment of heart disease, even more so than older women and certainly more so than men.
Thank you for that, Dr. Duvernoy. Dr. Saberi, I saw you unmuted if you want to add anything.
I just was going to add that I think the term chest pain can also be problematic when we're talking about what the symptoms are, in the sense that I feel like when I've talked with, many patients who've had heart attacks, that they'll say, well, it wasn't that bad, and maybe our perception of what the pain should be during an event is a little different. It can be pressure. It can be a heaviness sensation. It can just be in like an off-putting kind of discomfort. It doesn't necessarily have to be on the left side of the chest. It can be in the middle of the chest. And unusually it can be in the right side of the chest, but it can happen. It can happen in the jaw or in the side of the neck, or even in the scapular, kind of the upper back. It can also really present itself as a discomfort kind of substernally, just at the top of the belly, almost like reflux. And some people really do confuse the symptoms of reflux, heartburn, and chest pain related to blockages, acute blockages in the coronary arteries. And they're difficult to discern. And just as the person who's experiencing it is having a hard time discerning it, we too have a hard time discerning those symptoms at times.
Thank you. I think that's a very important thing to add. In fact, as those symptoms were being described, I was like, wow, that does sound a lot like heartburn. That's very interesting. So the next question we have, so we've talked about the symptoms of heart attack. What are the symptoms of heart disease in patients assigned female at birth?
So I think something aside from the chest pain that we've talked about and the chest pressure, those types of symptoms, shortness of breath and fatigue can really be hallmarks of chronic heart disease. Also heart disease that not necessarily is related to blockages in the coronary arteries, because there are lots of other things that can affect the heart. Diseases of the heart valves, diseases of the heart muscle, diseases that may affect the right side of the heart, something called pulmonary hypertension. Many of those types of conditions present with shortness of breath with exertion and easy fatigue. Sometimes laying down makes people feel like they're smothering and they kind of have to sit up so that they can catch a breath. They may get swelling in their extremities, or they may feel this sort of uncomfortable fullness sensation in their belly if they get swelling or fluid accumulation there. So those are all things that can be signs of a heart condition that is a chronic thing.
Thank you. Anything to add from our other two panelists?
Well, one thing I'd add to this discussion is many people overthink the symptoms that they're having. And a unifying theme I've heard from many patients who have had heart attacks is they just sort of knew that this was something different, something was wrong, something was really bothering them. And we have so many great therapies that weren't available even 20 or 30 years ago for people who are having heart attacks. Everything from enhanced medical therapy to taking people to the cath lab. And I'd advise people not to overthink this, because most of the patients we see in the emergency department have non-cardiac chest pain. I mean, they come with a worry, and we find out that thankfully they're not having heart disease. But we want people to come to the emergency department quickly so we can get these therapies to them as soon as possible. And they're better if we get the therapies to them sooner.
Thank you for that, Dr. Bisognano. Let's move on to our next question. Do heart health risks differ between transgender and cisgender women? And if so, how?
So I can start that question. I definitely am not an expert on transgender health issues. I will say that the hormone therapies used by transgender individuals, estrogen therapy in the case of transgender women and testosterone therapy for transgender men, may lead to cardiovascular risks that I think need to be discussed with those individuals, and that they need to be aware of. So things like clotting risk or thrombosis, like deep venous thrombosis or pulmonary embolism risk for estrogen therapy, and potentially an increased risk of cardiovascular disease for testosterone therapy.
Thank you for that answer. Dr. Saberi, I see you nodding. I don't know if you want to add anything.
That's my my general knowledge as well, and also my anecdotal experience that I have seen transgender women have much more aggressive coronary disease than a lot of their peers in the same age group later in life, primarily related to long-term hormone therapy. So I think not that we would, try to persuade somebody not to pursue those treatments because they're important, but probably to be vigilant about symptoms and to not ignore them so that they come to medical attention.
Thank you. Dr. Bisognano?
I would also add that there is a little bit more hypertension in transgender individuals, and the treatment goals are the same, generally aiming for a blood pressure less than 130/80, but it should be watched very closely, and using the same standard blood pressure drugs that we use.
If I could just add, it's really, really important for transgender individuals to have a good relationship with their healthcare provider, and to feel safe in coming to their provider with concerns, whether those are cardiac related concerns or other healthcare concerns. And I think that many of our clinics are identified as trans-friendly places and safe spaces for transgender individuals to come to with healthcare concerns. I know that my clinic has been that.
Thank you for that addition, Dr. Duvernoy. The next question that we have up, are heart attacks becoming more common for younger women in their 20s and 30s?
So I can start that. I think what we are seeing is an increase in risk factors that may make heart disease in younger women more common. And those things include rising prevalence of obesity, and probably most importantly, rising prevalence of diabetes. So those factors may be making cardiovascular disease and heart disease more common in younger women. I think the other thing that we are seeing is really an increasing risk of cardiovascular adverse outcomes in pregnancy. And so those by definition are going to be younger women. And we're really seeing very dangerous and alarming statistics as far as cardiovascular outcomes in obstetric care. We as a country, as a nation, need to do better in providing prenatal care and recognizing cardiovascular risk in pregnant women in our society.
Thank you. And that dovetails very nicely. You touched on this, but I think it bears repeating. Another question for you, Dr. Duvernoy. How does pregnancy affect heart health?
Yeah, so there's things to be aware of. It's hard. Sara and I, having both had pregnancies, can tell you that a lot of things that you experience during pregnancy when you're a cardiologist are like, oh my God, am I having a heart problem? Because you're short of breath when you're pregnant. And if you are a heart doctor, you're like, oh my God, could this be a heart problem? So there's some things that happen naturally during pregnancy that are just the physiologic changes that occur during pregnancy. We do tend to get more short of breath. We do tend to have a higher resting heart rate. Oftentimes we get swelling in our ankles, and those things are not necessarily indicative of a heart problem, but they can be. And so this is the tricky part where it's really important to get prenatal care, to see your obstetrician regularly, because there are things like peripartum cardiomyopathy, which is a disease of the heart muscle where your heart muscle gets weak all of a sudden, and you really you develop heart failure symptoms. You can't breathe, you get swelling. There is this phenomenon called preeclampsia, or progressing even to eclampsia, which is which we're finding out more information out about, but is still, I would say, a poorly understood phenomenon where women will develop high blood pressure, swelling, protein in the urine, and it can be a life-threatening condition if it is not properly treated. And sometimes the baby needs to be delivered preterm in order to reduce the risk to the mom if it is in late stages. There are other things that can happen. Heart rhythm disturbances are more common in some cases in pregnancy. Those can be treated. So those are some of the things that come to mind for me.
Pregnancy is the biggest stress test that a woman will experience in her kind of young life. Our plasma volume, your blood volume, basically doubles through the course of your pregnancy. So you're holding on to a lot of fluid for yourself and the baby. And so, of course, you're going to be more winded. And of course, you're going to have a little bit more swelling around the feet and ankles by the end of the day. And what I think is hard, is because those things are all common occurrences, especially in the last trimester of pregnancy. It's hard to differentiate those from actual pathology, disease going on that may be happening concurrently, because pregnancy is not pathology. It feels like it at times, but it's not. So what I always tell my pregnant patients with cardiovascular diseases is that, if you're feeling, just call me, call, because having the conversation actually is important, and it lets me know that you're concerned about something, and we can follow and see what's the progression here. If it's just kind of a little bit of swelling and a little bit of shortness of breath that seems in keeping with what's going on with you, fine. But if we bring you in and find that no, your ankles are the size of your thighs, that's not normal. That needs to be investigated. Doing a blood pressure check and making sure, are you having preeclampsia? Checking the urine and seeing, is there protein being filled here? Those are really important things. So I always tell friends, colleagues, my patients, like, not to ignore those symptoms, because I think we've been conditioned to. We women have been told, oh, that's just because you're pregnant. But because the symptoms can be difficult to differentiate, it's real important to contact your OB. And also, if you're getting this is just pregnancy, if it's persisting and progressing, to push back, to be an advocate for yourself and say, nope, this is not, I need to be seen, this is not okay.
Thank you for that. I don't know if you had anything to add, Dr. Bisognano.
The only thing that I would add is that when people have hypertension during pregnancy, and not the severe hypertension that the others have mentioned, it's sometimes a sign that someone is predisposed to having hypertension later in their life. It often goes away after the pregnancy, but it means that you may be an individual who in your 40s, in your 50s, may want to be a little more watchful of your blood pressure because something may be brewing there. And again, it's really allows you to focus on watching weight, maintaining physical activity, and if necessary, some of the medications that there are to treat high blood pressure.
Same with gestational diabetes, right? That is also a marker that you may be more prone to developing diabetes later in your life when you're not pregnant. And so we need to do primary care and look.
Thank you for the answers to that question. I have a couple of questions for you here, Dr. Saberi. What are the most common or most serious inherited heart and vascular diseases that affect people assigned female at birth? And what are some ways that you treat those conditions with your patients?
There are very few diseases that are cardiovascular in nature that are very specific to women and that wouldn't also affect men. So I'm going to start with just diseases that affect both genders pretty equally. And those are kind of inherited cardiomyopathies and inherited valvular disorders. So things like hypertrophic cardiomyopathy, a primary heart muscle disease that is genetic in nature and is passed down from one generation to another in a family, affects men and women equally. It affects about 1 in 500 people. So it's not very common like coronary disease, but it's also not that rare. There are other cardiomyopathies, some muscle disorders involving the heart muscle that are more unusual, but also heritable. So what's called the opposite, essentially, of hypertrophic cardiomyopathy would be dilated cardiomyopathy, where the heart actually becomes bigger, the chamber sizes become bigger, but the walls themselves actually thin out and the squeeze function of the heart becomes abnormally low. Those are less common. And then more unusual diseases, I think we'll kind of stay away from because they're not that relevant. The most common heart valve condition, actually, that's heritable is a bicuspid aortic valve. So the aortic valve is a doorway that sits between the bottom chamber on the left ventricle, and the aorta, the main blood vessel that carries oxygen-rich blood out of the heart into the rest of the body. That doorway should have 3 little curtains to it. And sometimes 2 of them can be fused together such that it looks and acts like there's only 2 curtains, or someone's actually born with 2 curtains. And those curtains should really be paper thin, but when they are abnormal in their anatomy, they're much more prone to becoming thickened, calcified, and not opening very well. And so can basically be a prevention to normal blood flow out of the heart. And that's also heritable, though it's the genetics and the heritability around that is more complicated. It doesn't seem to be just a single gene variant that causes that, like the way it is in hypertrophic cardiomyopathy. Probably the most dangerous vascular disease would be Marfan's disease. This is a vascular disease that involves some of the proteins that make up the blood vessel wall that can be abnormal. So it's a genetic change that results in an abnormal protein that then results in abnormal structure and function of the blood vessels. And the one that's primarily affected is the aorta, that big blood vessel that comes out of the left ventricle, where kind of it becomes more compliant. It shouldn't have like as much give as it does in Marfan's, and so it's more prone to tearing, where the layers of the blood vessel can kind of come apart from each other, or rupture, where the blood vessel would actually burst. And that is, as bad as it sounds, pretty scary. And so it's an unusual vascular disease, but one that has other systemic kind of manifestations, and so one that we can certainly recognize in clinical practice. And we worry about that because in pregnancy, one of the other things that happens, like I said before, is that blood volume increases. There's a lot of hormone changes that happen, and because of that increase in blood volume and the hormone changes, women can be more prone during pregnancy to having tearing of the aorta or aortic dissection. And so we monitor those women very closely. There is a specific kind of genetic condition that's more common in women. It's disease of the blood vessels that we don't also understand very poorly, but has definitely genetic components to it. And that would be kind of coronary artery, spontaneous coronary artery dissection of kind of fibromuscular dysplasia of the artery. So again, abnormalities in the ways in which the blood vessel muscle components are formed such that they're prone to tearing, that are the layers coming apart from each other. And that can also be quite dangerous. And again, pregnancy is a time where women are more prone to things like that happening just by nature of the fact that they're under this continuous hormonal and physiological stress. That was a lot of talking, sorry.
No, not at all. That was a fantastic answer. I think my next question that we have is, how does being overweight impact heart health in women? Do different factors such as age increase or perhaps decrease risk?
So being overweight certainly is a risk factor for disease processes that put you at higher risk for vascular disease. So obesity is a risk for increased blood pressure. Those go hand in hand. Obesity for developing diabetes. And so those two conditions are more significant risks for vascular disease like strokes and heart attacks. There are other things. So obesity means that there's kind of a larger mass that the heart has to deliver blood to. And so the heart muscle will become thicker in order to be able to generate the force it needs to deliver blood. And so that you can see the heart muscle become thicker as a result of obesity. And with that thickness comes stiffness of the heart muscle. So it acts more like a basketball than a balloon in the way that it gives. And that stiffness can actually result in shortness of breath, activity intolerance. And we're not talking about panting. We're talking about being aware of your breathing and having it be a little bit more uncomfortable when you're climbing stairs, when you're trying to do your 2-mile walk with your girlfriend, when you bend over and sit up. And so those are the ways I think of primarily in a lot of the common themes that I see amongst my patients. I'm not sure what John and Claire would have to say about it.
I would certainly agree. I mean, obesity is a final initiator of a whole number of problems, including hypertension, lipid issues, blood sugar control issues, and the average weight of the average American has gone up by about 28 pounds since 1976. And with that, the prevalence of high blood pressure, diabetes, cholesterol issues, which downstream all drive heart disease and stroke and kidney disease, has gone up. So I think as a society, we're beginning to do some of the right things in getting unnecessary calories out of certain soft drinks, pastries, snack foods. But I think we still have a long way to go, because it really is a major public health problem when the average weight of a population has gone up that much.
Thank you. Thank you all for those answers. My next question is for Dr. Bisognano. What is metabolic disease and how common is it?
Well, it's a good question, because what we've really been discussing over the past couple of minutes is metabolic disease, really a disease that starts off with overweight and then moves to the next step of a slightly higher blood pressure. And I'd advise people that, normal blood pressure is less than 120/80. If you're going to your doctor and you're seeing a 130, seeing a 135, that's not normal. It's really it doesn't necessarily have to be treated aggressively with medications at that point, but that's a sign that of the future. And it should be a motivation to look at your lifestyle, look at what you're eating, and see if any small changes can be made so you can reverse the increase in blood pressure, increase in weight that's happening. Once one has gained a significant amount of weight, it becomes increasingly difficult to exercise. There can be joint issues. It's just difficult to exercise. And it also means it's fallen out of your daily habit. And when the weight is going up, the blood pressure is going up, it's an opportunity to change one's lifestyle. And I often advise people, if you're going to change your lifestyle, it has to be a change that you can manage for 6 or 12 months, or really better yet, a change that's permanent, because you don't want the weight to continue to drift up. So back to your question, what is metabolic syndrome? It is this whole constellation of weight gain, abnormalities in blood sugar tolerance, mild increases in blood sugar, increases in blood pressure. When you go to your doctor and they look at your cholesterol panel and say, this is okay, but it's not ideal. That's the time when it might be easier to change lifestyle and prevent metabolic syndrome and everything that goes along with it.
And in terms of diets, is there a specific diet, perhaps Mediterranean, intermittent fasting, keto, that you recommend for women to improve their cardiovascular health? Do supplements or omega-3s help?
Well, that's a good question, because if you go to the diet aisle of what we used to call a bookstore, which I think is more of an online bookstore now, there are tons of diet books, which suggest to you that nobody has exactly the one right answer that there is. I generally advocate the standard American heart diet, which is high in fruits and vegetables, high in unprocessed foods, beans, vegetables, fruits, with a minimum of red meat, tilting a little bit toward more fish, more chicken, less red meat, and certainly the things that we all know are bad to use in moderation, highly sweetened foods, processed foods. But that diet doesn't work for everybody. And what I often find is anything that will disrupt someone's eating plan, whatever's gotten them there in the first place, anything that disrupts it, whether it's a calorie restricted diet, high protein diets, lower carbohydrate diets are often useful in changing someone's initial food choices, but really being more aware of what one eats. Just simply having a food diary where you diligently write down every day what you are eating often will make you realize that you're eating far more calories than you think. That 200-calorie donut that you would have once in a while is actually 450 calories. That serving of pasta, which 2 cups seems reasonable, is actually 375 calories and 500 or 600 if you add enough butter to it. So getting back to your original question, anything that disrupts one's bad eating plan is a good start, but also to find an eating plan that you can persist with over a long period of time. A weight loss of any more than a pound a week is usually not sustainable for more than a couple of months. So it's always, people start diets, you lose the 5 pounds in the first 2 weeks, and maybe another 4 pounds in the next week or two. That's not a sustainable differential in intake and output in calories. So I often recommend small changes that you can persist with for 6 or 12 months, and that'll get the weight down. It also will change your overall approach to food.
Thank you.
And if I could just add, I think what John indicated is really the crux of the matter. There have to be changes that people can sustain, and a short-term crash diet, or I hate to say it, but a keto diet, oftentimes those things are not sustainable. It's very difficult for most people to entirely cut a whole food group out of their diet and stick with that over the long term. So I always tell my patients to try an approach to eating that is healthful and more mindful, but that is also enjoyable for them. Because if it's not enjoyable, if it feels like a chore and you're eating cardboard or what seems like grass and twigs every day, you're not going to stick with that. I do have good friends who have chosen a vegan lifestyle, and I think that that is a very, very healthy lifestyle for people with cardiovascular disease. I also recognize that it's not what is going to be palatable probably to the majority of Americans. I think if you can, if you enjoy cooking in a vegan lifestyle and can stick with that, that's a great thing to do. But like I said, it's not sustainable for maybe even the majority of people. A Mediterranean diet, and that's a little bit nebulous sometimes. What does that really mean? But a diet that, like John said, is more high in vegetables and fruits, fish, not so much red meats, not saturated fats, healthy fats like olive oil, nuts, legumes, that type of a diet, most people find pretty tasty, and most people are able to stick with that more. So I often recommend that type of a diet.
I think these answers are going to be very heartening to people, making these long-term changes, not trying to do something that is just so extreme that you can't even maintain it over a long period of time. So thank you for those answers. My next question, I'm going to push it to Dr. Saberi. How does cholesterol play into women's heart health? When should women start having their cholesterol and heart health checked?
So there are different, I think, issues with cholesterol. There are familial, again, genetic disorders and cholesterol components that actually can put men and women at much higher risk of heart attacks and strokes. But in people in whom that isn't a factor, then it kind of falls in line with Dr. Bisognano's recommendations and assessments about how it affects health in general. So the higher the cholesterol, especially things, markers like triglycerides, I think of as that's your like dipstick of what you ate that day, and how much you mistreated your body that day when we checked it, as opposed to an LDL, where I think of that more like, so that's kind of like the blood sugar in a diabetic, where there's like the hemoglobin A1C is like the 3-month marker of where your blood sugar has been. That's how I think about LDL. It's kind of like a longer kind of look at where cholesterol has been. And Dr. Bisognano is by far and away much, much more of an expert than I, so he should chime in anytime he wants. And so it does affect health because the cholesterol of many different types, and it's not just one thing, there are different types. They actually can damage the blood vessel wall. And once they kind of tack onto the blood vessel wall, they create this pattern of injury that then becomes this self-fulfilling prophecy, where the blood vessel wall becomes injured. All of your, army of inflammation soldiers come rushing in to try to repair that injury, and in the process actually create more of a problem. And over time, that can lead to blockages in the coronary artery and kind of narrowing of the passageway where blood can go through. So it is definitely a risk factor for strokes and heart attacks. And the recommendations are that women who have risk factors for coronary disease, including high blood pressure, diabetes, smoking, and a family history of early onset coronary disease, first have their cholesterol checked sometime around the age of 30 to 35. That age cutoff becomes younger in men. That's recommended in men ages 25 to 30. Now, if women don't really have any significant risk factors for coronary disease, the first cholesterol really should be checked in women around age 45, and in men, again, a little younger at age 35.
Thank you for that. The next question that I have coming up is for Dr. Bisognano. How do you recommend your female patients start to incorporate a more active lifestyle? Sometimes it's hard to get started, and it can be even harder to sustain.
Well, that's a great question. And I have a very similar approach to exercise that I have to diets and calorie restrictions. That it's important to find something that you can tolerate over the long term. Now, one of the unfortunate things about New Year's resolutions, particularly in states like Michigan, is everybody, sits there at, December 30 and 31, thinks very hard about what the resolution will be. And it's always the same. Most people's resolution is, I'm going to eat better, I'm going to lose weight, you're going to be more active. And then the huge challenge hits everybody. The temperature goes down to 2 degrees and it snows on you. It makes it very difficult to do. It's a shame that New Year's isn't at the end of March when the weather actually starts getting better. So what I'm suggesting here is to find something that you could do at the present time that's reasonable, something that you can do every day. And it may just be getting out of the house and walking around the block once. And after a few days of that, you may find you walk around the block twice. And on that day where it's 0 degrees and snowing all day, you miss a couple of days. And that's the best you can do, not to be too hard on yourself, but to always push forward, to always keep that goal in mind that when April comes, and April always does come, May does come, that you're in a better shape to increase your exercise level, to ramp up the exercise a little bit, and try to find an activity that you find enjoyable and tolerable. So again, small changes that can persist over time. And a little bit of the change on the diet, a little bit of the change on the exercise translates into better health, weight loss, better cholesterol panels, better blood pressure, better glucose tolerance. Again, finding things that are reasonable. Somebody once said everything in moderation, including moderation. And this is what I agree with, that push yourself a little bit. And if you fall back, if you have that day, those couple of days where you do nothing and and you have those 3 slices of pizza, it's understandable. Don't be too hard on yourself, but refocus and go forward and keep your eye on the goal, which is being a healthier self.
Thank you so much for that answer. The next question is an audience question, and I'm looking at it, I'm probably going to mispronounce something. I'll try and pronounce vitamin correctly for our American audience and not say vitamin. But the question reads, I have homocysteine. My doctor told me to start taking vitamin B12 and folic acid. Anything else suggested to help this? Does having this increase my chances of getting heart disease or having a heart attack? And I've just been told it's homocysteine.
Well, there's some evidence that an increased homocysteine level, particularly a markedly increased homocysteine level, will increase one's chances of vascular disease. Perhaps it has an association with an increased heart attack and stroke. But the vitamins that you mentioned will bring down the homocysteine level at high doses for a number of people. And they're probably reasonable to do under certain circumstances. But what I would advise people to do is to focus on risk factor modification very intensely that we know something about. We know that we have good evidence. If someone has a high homocysteine level, they may also have a high LDL, bad cholesterol level. And we have medications and lifestyle changes that really focus well on decreasing LDL cholesterol, which translates very clearly into decreases in heart attack and stroke.
Thank you for that answer.
There may be other views on this, or other approaches.
I don't have anything to add to that.
The next question I have, we can send to Dr. Saberi. Heart attack or anxiety or panic attack? How do doctors tell the difference? And does this perhaps differ for women?
So that's also challenging, like telling a heart attack apart from having heartburn. Things that I think of that I think are pretty specific to anxiety and panic attacks are tingling around the mouth, kind of like a numbness sensation around the mouth or in both hands or in the legs that's going on at the same time. That often goes with kind of hyperventilation, which is more common experience around anxiety and panic attacks. One of the hallmarks of panic attacks is this sense of impending doom, but I actually think that a lot of people who are having an actual, vascular event of multiple types actually also experience that impending sense of doom. So I don't think that really tells them apart. There are, so chest pain, pressure, heaviness that wakes you up in the middle of the night that's associated with nausea, like a sense of clamminess. Those things can happen with both, but I think it's a little bit, so how you tell is by actually doing an EKG in that instance and maybe having a look at some blood markers to look to see if there's evidence of injury to the heart muscle. So in the end, I always, especially if it's like the first instance, like you don't have a history of anxiety, you don't have a history of panic attacks, then your fallback shouldn't be that I'm having anxiety and that I'm having a panic attack. You should get checked out and have the other corollary workup done in order to see whether or not that's what's going on. I always tell people I would much rather that you be annoyed about the experience of coming into the emergency room and waiting around for all this stuff to be done. And the waiting around is important because time and progression over time is actually very much a part of the assessment of what they're doing in the emergency room. But I'd much rather that you be annoyed about all of that than for you to be regretting the decision of not coming in for an evaluation, because that's a much harder thing to get over in the end. I don't know if either Dr. Duvernoy or Bisognano have other things to add in terms of how you tell apart symptoms of panic and anxiety from ongoing heart attacks.
I mean, I would echo everything that Sara said, and John said this at the beginning of our discussion. We'd much rather have you come in and get checked out and be able to tell you, we don't think this is your heart, we've done the right tests, and have you feel sheepish or foolish. That is okay. It is okay. We would much rather see you and be able to tell you that things are okay. And, you know, if you have this condition and you've had these types of attacks before, then maybe you'll have a better sense of whether it is a panic attack. But if you're not sure, please err on the side of caution and come in and get it checked out.
Right, and then this is what we do, and this is why we come to work in the morning and why we're here. But we also have the advantage that we have blood tests and EKGs and other imaging studies, and you don't have to wonder. We can figure this out with you.
Thank you all three for that answer. Next question we have up for Dr. Bisognano. What do you tell women who are having trouble controlling their high blood pressure?
Well, I think for women who are having trouble controlling their high blood pressure, we first start off with the standard evaluation. And one thing is many people will eat a lot of extra salt in their diet, and there is an association with an elevated sodium intake or salt intake with high blood pressure, particularly in older people who may have a little bit of abnormality in their kidney function. Restricting sodium can make a big change in one's blood pressure. And when one eats extra calories, usually the extra calories, so this goes hand in hand with diet. When one eats extra calories, usually the extra calories are foods that are high in salt. You know, the potato chips, the extra servings of stuff, the fourth slice of pizza or the second slice, I mean, that comes with a lot of salt. So in calorie restricting yourself in order to decrease your weight, it also decreases your sodium intake quite a bit, and that can be a marked decrease in sodium intake. The weight continues to be an issue. Exercise is an issue in treating high blood pressure. One thing that in people who are perhaps a little bit heavier, I always screen people for sleep apnea because that has a high association with high blood pressure and the state of being overweight. Treating sleep apnea will decrease blood pressure by 5 to 7 points in some people. It doesn't decrease blood pressure in other people, but on the other hand, if you have sleep apnea, it's something worth treating, whether it affects your blood pressure or not. So I always screen people for sleep apnea. And signs of sleep apnea are snoring, stopping breathing overnight. If anyone ever says you stop breathing and take down a big snore in, there's a big chance you have sleep apnea. Morning headaches, the desire to take daytime naps that's really almost uncontrollable. So that's worth thinking about. Many people who have high blood pressure that's difficult to treat simply require more medications. And we're fortunate that, naturally we want to minimize the number of medications you're taking, but we're living in really a golden era in medication treatment of high blood pressure. That pretty much all of the medications are generic. Some of them are downright cheap. A lot of the insurers have zero copays for a lot of high blood pressure medications. And most blood pressure medications will lower blood pressure by 10 to 12 points at their maximum dose. So if you're starting with a blood pressure of 180, you simply may need more medications. And the side effect profile is pretty low on at least the first 4 or 5 medications that we would generally choose. So I think the bottom line here is, again, to focus on reasonable weight loss, reasonable calorie restriction, reasonable exercise therapy, but also to be open to the therapies that started coming out in 1956, medications that have been shown to decrease heart attack, stroke, and kidney disease.
Thank you very much. I don't know if our other two have anything to add.
I would just echo what John said. In this day and age, we can control blood pressure. We have the tools. We just need to be willing to use them, and we need to partner with patients. It's not a sin or a bad thing to have to take several medications for blood pressure. And the truth is that most patients with high blood pressure need more than one medication to control it properly. So that's not a bad thing. We can try to make it as convenient as possible with, once a day or twice a day medications. But we just need to partner with our patients to get the blood pressure down.
And we often make it sound like it's a sign of failure if you have to take a blood pressure medication, and it shouldn't be that way. We send you out at first hoping that you could improve your blood pressure with diet, exercise, weight loss, all the good things that we've talked about previously. But most people, or at least a large number of people, simply can't do that. It's hard to incorporate this. If you're hypertensive and you look at your relatives, you probably notice that a lot of them have high blood pressure, which suggests that there's a significant genetic component of it. So it's not entirely your fault. And I think we can just be fortunate that we have medications, that you don't have to be out there with a blood pressure of 180 like you would have had to be in 1950, waiting for your stroke. We can fix this.
Thank you so much for these answers. Unbelievably, we're almost out of time. I think we have 3 questions left, so I'd like to get through them. The first couple of questions I have: do statins have more significant or common side effects in people assigned female at birth? Does that mean people should perhaps be nervous about taking them?
So I don't know of any more common side effect profile in women than in men for statins. Statins are some of the most widely prescribed classes of medications that we have, and there is a ton of stuff everywhere you look, especially in the internet, about all the things that statins can do to you. And the truth is that statins have a very favorable side effect profile. Yes, they do cause some side effects in some small proportion of people, but they're generally very well tolerated. And so we can work with you if you're having things that you think might be side effects to statins. We can switch drugs. We can work with you on dosing strategies. I personally do not know of more common side effects for women. I don't know if John or if Sara, if you guys have any other information.
Okay, excellent. Let's quickly talk about medical research. Actually, you know what? Let's sum up our conversation today. What is the top thing you recommend women do to enhance heart and vascular health? And let's go to Dr. Saberi first.
Get moving. That's it.
Thank you.
If you smoke, stop smoking.
And to find something you can continue to do, push on. If you pause, just regroup and push on again.
Fantastic. It looks like that these are all the questions that we've had today. I'm really privileged to be part of this group. Thank you so much to our panelists for answering all these questions, such a large variety of questions. I'm sure there's lots of value to this, and you'll probably be seeing follow-ups on our blog as well about this topic. And definitely thank you to our viewers for being here as well. So everybody have a good afternoon. Thank you.
Thank you so much.